Good afternoon, everyone. My name is Sharon, and today I'll be discussing respiratory infections in people with chronic respiratory diseases. It's actually quite a broad topic, so I've tried to make it as concise and as clinically relevant to us as possible. So this will be the outline of my presentation. I'll be talking about the definition of chronic respiratory diseases, what the epidemiology is, the approach to chronic respiratory diseases, what our normal respiratory flora and lung defenses are, what the pathophysiology of infections are in chronic respiratory diseases, what microorganisms are implicated in both acute and chronic infections, and investigations, treatment, and prevention of infections in chronic respiratory diseases. So starting off with the definition of chronic respiratory diseases, there's actually no consensus definition of what chronic respiratory diseases are. But looking through the literature and several papers, the most concise definition is that it's an umbrella term used to describe conditions that affect the airways and lungs, causing chronic respiratory symptoms. It has an impact on both an individual and an healthcare level, and is one of the top 4 leading causes of non-communicable diseases globally. So why is it relevant to us in infectious diseases? Well, infections in chronic respiratory diseases may result in accelerated disease progression, reduced quality of life, an increase in morbidity in the form of myocardial infarctions and other cardiovascular events, as well as mortality and excess healthcare costs, which are secondary to unscheduled visits, treatment costs, and hospitalizations. Just to give you some context, in 2005, the EU had reported that they had spent £38.6 billion in treating patients with chronic respiratory diseases, and it's been thought that the US is spending about $50 billion a year treating patients with chronic respiratory diseases. So really this subgroup of patients are quite unique, but also they are at risk of quite significant morbidity and mortality, as well as quite a lot of associated healthcare costs as a result of that. When we look at the epidemiology of chronic respiratory diseases, this is taken from our World in Data, and it looks at, these were the latest stats in terms of the causes of death globally in 2019. And you can see that chronic respiratory diseases account for 7% of all deaths globally. And under chronic respiratory diseases, they have COPD, asthma, and others. So it's one of the top 3 leading causes of diseases on a global scale. This is taken from the WHO report in 2019, looking at the number of deaths attributable to non-communicable diseases. And in this case, it's respiratory diseases, and you can see it ranges from 27 to 1,146,371 deaths globally. Within this very same report, they've reported years of lives lost, which is the premature mortality at 71.1 million deaths, and years with disability, which impacts quality of life at 32.4 million. And in 2019, it was estimated that there was 77.6 million new cases globally of respiratory diseases, and that this was an increase of about 49% from 1919. This is WHO stats again, looking at the year 2019 in South Africa, and the number of deaths attributable to respiratory diseases was 19,525. Looking at the number of deaths per year, so you can see over a 4-year period from 2016 to 2019, that respiratory diseases were still amongst the top 4 causes of death in South Africa. This is taken from Stats SA, and you can see over a 20-year period from 1997 to 2018 that chronic respiratory diseases is still number 4 on a national level as well. So our mortality back in 2008 was about 2.4% of all deaths, of all non-communicable disease deaths. But as of 2018, it's increased to 5.4%. And 90% of all these deaths were due to COPD, accounting for 62%, and asthma accounting for 22.3%. So quite significant and quite impressive numbers. Now, looking at an approach to chronic respiratory diseases, so this is not really something that we need to know, but it is good to have an idea of how extensive this patient population is. So my little picture here on the left is just a patient having spirometry done. And I really tried to find a nice, concise classification of chronic respiratory diseases. And really the best way looking through papers was to divide them according to obstructive and restrictive lung diseases. It doesn't really have an impact from an ID point of view, but it's just to have a nice idea of how to classify these diseases. So from an obstructive point of view, the most common causes are COPD, which encompasses chronic bronchitis and emphysema, followed by asthma and bronchiectasis. And then you have uncommon to rarer diseases, which includes interstitial lung diseases, but I'll chat about this in the next slide, as well as miscellaneous causes like kyphoscoliosis. When you take something like bronchiectasis, this just tells you, this just illustrates the causes of bronchiectasis, traditionally classified as either cystic fibrosis related bronchiectasis or non-cystic fibrosis related bronchiectasis. And there are various causes of that, either post-infective related to immunodeficiencies, secondary to mucociliary clearance defects, bronchial obstruction, autoimmune diseases, and congenital disorders like alpha-1 antitrypsin. This is interstitial lung diseases. So again, just to see, to be a bit more systematic, you have etiologies that are unknown. So this is the idiopathic interstitial pneumonia group, where you have IPF and non-IPF, and this is diagnosed on lung histology, together with exclusion of known etiologies, and sarcoid and LAM fall under this. And then under known etiologies, you have inorganic exposure, which is usually your occupational exposure, and then organic exposure, smoking, drugs, and connective tissue diseases. So you can see how extensive this particular group of patients are with chronic respiratory diseases. Now, before we move on to the pathophysiology of chronic infections and chronic lung disease, it's important to understand what the normal respiratory flora are and what our normal lung defenses are. So the image on the left here shows the respiratory tract, which starts from the nasal cavity all the way down to the alveolus. And when we look at the upper respiratory tract, which is composed of the nasal cavity, the nasopharynx, and the oropharynx, the first three columns just illustrate the normal commensal organisms in those various sites. As soon as we move on to the lower respiratory tract, previously it was thought that the lungs were actually a sterile environment, but of recent research that's been going on, this has been debunked, and it's been found that the lung has its own special microbiome, with organisms such as Veronella, Prevotella, and Streptococcus species being commensal organisms. So just like how you have the gut microbiome and the skin microbiome, you also have the lung microbiome, which was previously thought not to exist. Now, when it comes to lung defenses, this was a nice table that just illustrates the two major components of lung defenses. So you have the airway and the mucosa, and then you have alveolar spaces. Under the airway, you have luminal defense mechanisms, epithelial cells, blood-derived cells of the mucosa, and under alveolar cells, you have nematocytes, type 1 and type 2, and alveolar macrophages. And we'll chat a bit about each of them in the subsequent slides. So looking at the actual anatomical structure of the respiratory tract, the nasopharynx and the airway bifurcation represent anatomical barriers that prevent microorganisms or particles that are more than 2 to 3 micrometers from entering into the lower respiratory tract. You then have the cough clearance, which is this forced expiratory maneuver that allows turbulence and shearing forces in the major bronchi and trachea to extrude material from the lower airway into the upper airway and then eventually outside of the body. You have mucociliary clearance, which has two parts. You have the mucus component, which is made up of mucoglycoproteins and proteoglycans from the surface of epithelial cells and glands. And then you have the cilia, which are found on the epithelial cells in the respiratory tract. And these move particles from the terminal bronchioles to the trachea by ciliary beads of the epithelial cells. And this provides an anatomical barrier to microorganism invasion. You also have secretion of antimicrobial substances such as lysozyme, which degrades the glucosidic linkages of bacterial membrane peptidoglycans, lactoferrin, which reduces available elemental iron, which is needed for bacterial replication. And then we also have formation of secretory IgAs from epithelial cells, which block bacteria from crossing the epithelium, neutralize toxins and viruses. They activate the alternative complement pathway and opsonize bacteria as well. When you look at the epithelial cells themselves, they form an anatomical barrier through formation of tight junctions and desmosomes. They also recruit inflammatory cells by release of arachidonic acid derivatives, which allows adhesion of neutrophils and mononuclear cells to an inflamed area. You also have secretion of beta defensins and leukotrienes and lactoferrins and reactive oxygen species, which constitute the antimicrobial substances. You also have blood-derived cells, so in the form of T and B lymphocytes, which react to pathogens, sometimes even in the absence of preliminary priming. You have type 2 pneumocytes, which produce surfactant, and they produce protein A and D that enhances phagocytosis and killing of microbes. And then you have alveolar macrophages, which invade microorganisms, recruit neutrophils and other mononuclear cells via IL-1 and tumor necrosis factor. And they also produce antimicrobial substances such as lysozyme, defensins, reactive oxygen species, and complement. The one cell that's not depicted here is the dendritic cell, which is also responsible for stimulation of T cells. And all these defense mechanisms are in play. And if you actually think about it, we inhale about 10,000 liters of air per person per day. So all of these defense mechanisms, both anatomically and functionally, work together to prevent invasion of microorganisms. So what happens with patients who have chronic respiratory diseases? They essentially have an immunocompromised lung. So they have immunocompromised lungs where there is both an anatomical as well as a functional defect in all these defenses that I've just spoken about. But it's important to also understand that when you have impairment of these defense mechanisms, you're not going to lose all the defense mechanisms. So often these patients are colonized with bacteria that are different from a healthy lung microbiome. And the reason for this is not only because of this immunocompromised state in the lung, but also because these very microorganisms have to be able to adapt to the host environment and evolve over time within the host. And how researchers have found this is by research on cystic fibrosis associated pathogens, and mainly Pseudomonas. And what they had done is they actually did whole genome sequencing on sequential Pseudomonas isolates in cystic fibrosis patients over a period of 8 years. And they found that over time, the various pseudomonal isolates had actually had reduced virulence expression. And that's how they were able to almost coexist without really causing much of a problem in patients who have chronic lung disease, particularly in this group, cystic fibrosis. So you have downregulation of virulence factors and pathogen-associated molecular patterns to avoid detection by the host. And there's different mechanisms involved for bacteria, viruses, and fungi, because obviously, if you think about it, the immune defense against each of these various classes of microorganisms differ slightly. So this is a bit of a busy table, but it's taken from this paper by Cullen and McLean, and it's actually just a nice table just illustrating how bacteria have adapted during chronic infections. And you can see here the column on the left is looking at the pathogen, and mostly studied has been Pseudomonas. The column here on the middle is looking at adaptation, but I will summarize this. And then the column to the right is to look at effective adaptation, and you can see the disease states in which it was most studied on was cystic fibrosis. So in terms of adaptation of bacteria to be able to chronically colonize patients with chronic respiratory diseases, you have point mutations, gene conversions and rearrangements, insertion of foreign DNA and deletions, as well as horizontal gene transfer mechanisms. In addition to this, you also have antibiotic pressure, which can result in diversification of populations with subpopulations that often coexist. You can also have antimicrobial resistance, and that's as a result of development of efflux pumps, porins, altered membrane permeability of these organisms, enzymatic modification, modification of the lipopolysaccharides, as well as biofilm formation. So this is how these bacteria are able to chronically colonize patients with chronic respiratory diseases. In terms of viral infections, the image on the left is just to illustrate what normally happens in a healthy lung. So you have a virus infection of the epithelial cells, you get this robust interferon response, which is Th1 driven, and that results in this robust antiviral response with minimal inflammatory responses, and that results in minimal inflammation and the short-lived upper respiratory symptoms. The model that they've used is in an asthmatic patient where you have impaired interferon responses. So you have virus infection of the epithelial cells, and as a result of this impaired interferon response, you have a predominant Th2 response and a deficient Th1 response, and that results in uncontrolled viral replication, resulting in cell necrosis, excessive inflammatory response, and that triggers an exacerbation of asthma. So it's not just in asthmatics, but also in COPD secondary to smoking, where you have impaired interferon production from both bronchial epithelial cells as well as peripheral blood mononuclear cells. And what happens is that you have this deficient Th1 response, which makes you predisposed to having viral infections. This image on the right here is to illustrate how patients have this secondary bacterial infections. Often we hear about this concept of secondary bacterial infections post a viral infection. And what happens is that once you have this inflammatory response to the virus, you have epithelial sloughing, mucus plugging, an increase in immune cell infiltration, as well as microvascular dilatation and edema. And what this all results in is impaired mucociliary clearance. And as a result of that, you get secondary bacterial infection, and that's how these patients are prone to getting bacterial infections following a viral infection. Now, the difference with viruses as compared to bacteria, because there are several studies that have shown chronic bacterial colonization in patients with chronic respiratory diseases. However, when it comes to viruses, it's really poorly elucidated, and there's a lot of clinical data that's lacking. There have been several epidemiological studies that have tried to look at persistence of certain viruses in stable disease states that these patients have. And to date, they really haven't been able to demonstrate a lot of viruses that are chronically colonizing the respiratory tract of these patients as compared to bacteria. When we look at fungal infections, so you need both the innate immune system as well as the adaptive immune system to be able to fight fungal infections. And again, in patients with chronic respiratory diseases, because they have an impairment in both innate and adaptive immune responses, they're more at risk of developing fungal infections. Now, this is quite difficult to read, and I really tried to get a better image, but I just wanted to illustrate here. So this was a study that looked at the various microbial species that were present in different regions of lungs in severe COPD. So just to highlight, the color red is representative of Pseudomonas, the color purple is representative of Haemophilus, and you can see in these various lung regions how the proportion of microorganisms differs. And it's quite interesting because you can see that within the same lung, you can have various regions that are populated by different microorganisms. And you can see that all these organisms that have been mentioned here, so Pseudomonas, Haemophilus, Stenotrophomonas, Lactospira, Burkholderia, Achromobacter, Staph, these are not the normal commensals that are found in a normal healthy lung. These are the sort of organisms that you get in patients with chronic respiratory diseases. Now, when we look at commonly implicated microorganisms, this is just to give a brief, just to contextualize what the main causes of infections are in this group of patients. And then we'll narrow it down to specific populations. Obviously, the ones that we see quite often are COPD, asthma, and bronchiectasis. So when we look at bacteria causing acute inflammation, strep pneumo, Haemophilus influenza, Neisseria species, and non-typable Haemophilus have been implicated. When we look at chronic infections, MTB, so Mycobacterium tuberculosis, NTM, which is non-tuberculous mycobacterium, Pseudomonas aeruginosa, Burkholderia cepacia, Staph aureus, and Stenotrophomonas multifilia have been implicated. When we look at viruses, rhinovirus is in the lead in terms of viral etiologies, followed by influenza and coronaviruses. When we look at fungi, acutely you can have dimorphic fungal infections, Aspergillus, PJP, and in chronic infections, you can again have dimorphic fungi, Aspergillus and Scedosporium, which has been implicated in cystic fibrosis. Now, when we look at culprit microorganisms in specific disease states, this is in COPD. So these are the microbial pathogens that are responsible for exacerbations in COPD. In terms of infective exacerbations, bacteria account for 40 to 50% of that proportion. And in terms of the main organisms that are implicated, you have non-typable Haemophilus, strep pneumo, Moraxella, Pseudomonas is isolated in very severe COPD, Enterobacterales. But again, this would be with patients with concomitant bronchiectasis and recurrent exacerbations. Haemophilus parainfluenza, Haemophilus hemolyticus, and Staph aureus, again, isolated infrequently, but it is one of the causes of acute exacerbations. In terms of infective exacerbations from a viral etiology, they account for 30 to 40%. So rhinovirus takes the lead in terms of which virus is number one, followed by parainfluenza, influenza, RSV, coronavirus, and then adenovirus. Atypical bacteria actually only account for 5 to 10% of exacerbations. And those organisms are mainly Chlamydia pneumoniae and Mycoplasma pneumoniae. And I've highlighted this because this has implications in terms of treatment for patients who present with COPD infective exacerbations. This is another table, again, just highlighting which pathogens are responsible for exacerbation. And then your column on the far right is looking at their role in stable disease. So in terms of bacteria, you have Haemophilus influenza again, strep pneumo, Moraxella. So these are your typical respiratory pathogens. And then in terms of viruses, again, rhinovirus, parainfluenza, influenza, RSV, corona, and adenoviruses. And then again, atypical bacteria form 1 to 5% of exacerbations in COPD exacerbations. In terms of fungi, the role of PCP in exacerbations is really not well defined. And in terms of stable disease, it is commonly detected, but again, its pathogenic significance is not well defined either. So when we look at asthma exacerbations, the ratio is slightly different. So you do get bacterial infections. So your typical respiratory pathogens like strep pneumo, Haemophilus, Moraxella. You can get atypical pathogens, but it seems to be predominantly driven by viruses. So you have more viral infections that are triggers for an acute asthmatic exacerbation. And the main culprits are rhinovirus, enterovirus, RSV, human metapneumoviruses, adenovirus, and polyomaviruses. When we look at bronchiectasis, you have bacteria. So again, Haemophilus features as number one, and then you have Pseudomonas aeruginosa, and then less commonly are the known typical respiratory pathogens, so strep pneumo, Moraxella, and then you have Staph aureus, Stenotrophomonas, and gram-negative Enterobacter. NTMs are a big group here in bronchiectasis patients and Aspergillus-related diseases. So the organisms that I've just highlighted, so Pseudomonas, NTM, and Aspergillus, are important to remember in this subset of patients because they shouldn't be ignored and treated as just normal commensals. So how do we determine whether an exacerbation is infective or not? And usually this is what happens in my head on a post-intake ward round or an ID cover week, and it's really quite difficult. So how do we decide if an exacerbation is infective or not? Are there clinical criteria? Is there a role of biomarkers in blood? Is there utility of microbiological results from respiratory samples? And is there any suggestive imaging that may be helpful? So when we look at clinical criteria for an infective exacerbation, an exacerbation is defined as an acute worsening of symptoms characterized by increased dyspnea, cough, sputum production, and purulence, and this applies to COPD and bronchiectasis. You'll see in the subsequent slides that when we look at an exacerbation of asthma, this really isn't part of the criteria. Now, the exacerbation can be defined either by symptom-based events or event-based definitions. And what does that mean? So when we look at symptom-based definitions, we rely on patients reporting worsening of their respiratory symptoms either to a healthcare worker or in their own diary. So it relies on the patient and the clinician's perception of the symptoms for diagnosis and severity of assessment without really an objective guidance for a standardized approach. So you can already see that the problem there is that it's quite a subjective tool. In terms of event-based definitions, this is where the condition has changed significantly enough that it warrants a change in treatment. So there have been various clinical criteria that have been proposed to define an exacerbation. However, the sensitivity and specificity are poor when it comes to using it to define an infection as the trigger for the exacerbation. And I put this table in just to illustrate that the causes of an exacerbation in COPD, yes, are mainly infective, but you can get non-infective causes of an exacerbation, mainly in the form of an eosinophilic inflammation, pulmonary embolus, congestive heart failure, myocardial infarctions, poor medication adherence, as well as ongoing smoking. So it's always important to remember that you can have non-infective exacerbations of these chronic underlying respiratory diseases. So various criteria have been used in COPD. This is a list of the various criteria that have been used to determine an infective etiology. So Anthonyson and the modified Anthonyson criteria have been well described. So the Anthonyson criteria was described by Anthonyson and his colleagues in the 1980s, and they described an exacerbation as an acute sustained deterioration of at least 2 symptoms, which includes breathlessness, increased sputum volume, and increased sputum purulence. And the rationale here was that increased sputum purulence and volume was more suggestive of an infective bacterial etiology versus a non-infective process. And the sensitivity for sputum purulence for an infective exacerbation was noted to be 94.7%, but only had a specificity of 15%. Later on then, there was a modified Anthonyson criteria, which looked at exacerbation as being one of the 3 criteria I've just mentioned, or you have one major and one minor symptom, and of the minor symptoms, they looked at cough, wheeze, nasal discharge, sore throat, and pyrexia. Again, trying to encompass symptoms that may be suggestive of an infective cause of the exacerbation rather than something that was non-infectious. This is the 2024 GOLD definition, which defines an exacerbation as an acute exacerbation, being acute worsening of respiratory symptoms of patients with COPD that result in additional therapy being warranted. This was the actual paper taken by Anthonyson looking at antibiotic therapy in exacerbations of COPD. And they actually back then had classified exacerbations as type 1, type 2, and type 3. Type 1 was if you had all 3 symptoms. So if you had breathlessness, increased sputum volume, increased sputum purulence. Type 2 is if you had any 2 of the 3, and type 3 is if you had any 1 of the 3. And if you look at the success in terms of exacerbation, and you look at the placebo group versus the antibiotic group, you can see in type 1, there was 31% who were fine from a clinical point of view with the placebo group, and then in the antibiotic group, 44%. If you were 2 out of 3, 45% were fine without anything, 54% were better, so a little bit better. And then if you were one of three symptoms, you can see the difference between the two groups is not that much. So again, although it does point to a likely infective etiology, it's really not the most specific. This is the table illustrating asthmatic exacerbations. So you can see here in terms of criteria, it's mainly based on clinical criteria and some biochemical criteria based on a blood gas. Bronchiectasis is similar to COPD, where you have exacerbation, which is defined as 3 or more of the following key symptoms for at least a 48-hour period. So you have cough, increased sputum volume and purulence, breathlessness, fatigue, hemoptysis, and in addition, the clinician must determine that there is a change in bronchiectasis treatment that is required. So all in all, the clinical criteria is helpful because it helps to direct you to think about more of an infective etiology of an exacerbation, especially if there is the presence of increased sputum purulence. Now, this is applicable because in low resource countries at a primary healthcare level, at a clinic level, if you're on call or you're on post intake, you don't necessarily have access to many of the other tests that I'm going to be talking about. And so your clinical criteria is going to be important here to determine whether this infection is the reason for why your patient has presented with an acute exacerbation. Now, are blood biomarkers helpful in determining whether an exacerbation is infective? So there have been systematic reviews and meta-analyses that have been done in acute exacerbations of COPD, and these have been extrapolated across to asthma and bronchiectasis regarding certain biomarkers, specifically CRP and PCT. The problem is that the cutoff values for CRP and PCT really do differ between studies. There was one study, a meta-analysis done in 2017 that suggested that a PCT value of more than 0.25 was suggestive of an infective exacerbation rather than a non-infective exacerbation. But this is the problem. The cutoff values, when you look at various studies, really range from 0.03 all the way up to 1. So it's not particularly helpful because you don't have a precise number that you can say if it's more than this, it's definitely going to be an infective exacerbation. Same applies to CRP. So this was in 2022 where they looked at a systematic review and meta-analysis of various studies that assess CRP. And again, you can see that the cutoff values really did vary. So from 1.5 all the way up to 30. There was an article that was published in 2017 in the New England Journal of Medicine, where they assessed 653 patients and they looked at a CRP value of more than 40 being used as a cutoff to say whether this is an infective versus a non-infective exacerbation. But again, you can see when you're looking at comparative studies, really there's no clear-cut cutoff value. So in terms of biomarkers to assist with an infective exacerbation, if it's elevated, it is helpful and it can be used as an adjunctive or supportive evidence for an infective process. But really, there's no exact cutoff in the literature that says beyond this particular point, this patient definitely has an infective exacerbation. In terms of the utility of microbiological specimens for infective exacerbations, we still run into trouble here. So bacteria have been noted to be isolated from culture in 50% of acute exacerbations, but it's also been isolated in 25% of stable patients. Viruses have been isolated in 30 to 50% of acute exacerbations, but about 10% have also been isolated in stable patients. So again, just because you isolate an organism, it doesn't necessarily mean that that organism is the cause of the exacerbation. In fact, numerous papers have actually discussed the fact that it's not the microorganisms within the new microbiome that's causing the infective exacerbation, but rather the acquisition of a new strain that causes an infective exacerbation. I just wanted to highlight here, and obviously the talk is not going to I'm not going to chat about this a lot, but it's just that isolation of Mycobacterium tuberculosis and non-tuberculous Mycobacterium in sputum and BAL should not be ignored in the subset of patients. And isolation of Aspergillus or adjunctive tests suggestive of Aspergillus infection should also not be ignored. And this is because of the morbidity associated with these infections and a subsequent decline in pulmonary functions. Can imaging suggest an infective exacerbation? So a systematic review and meta-analyses done in 2020 showed the following X-ray and CT findings. So this is chest X-ray, and you can see the various findings that they found in patients who presented with an exacerbation. And you can see, I've highlighted here, that consolidation is quite suggestive of an infective process. Looking at CT findings, again, you can see that there are various findings on CT, but again, I've just highlighted again, consolidation and ground glass opacification are more suggestive of an infective etiology. So now, how do we determine whether this is actually an infective exacerbation? And do we give antibiotics? And if yes, what do we give and why do we give it? So I emphasize this again, that you do need the clinical criteria here. So the Anthonyson criteria, and in fact, the modifying Anthonyson criteria is really helpful in determining whether this patient is likely to have an infective exacerbation. The supporting evidence from your blood biomarkers in the form of a CRP or a PCT is helpful. So it is helpful. And in terms of investigation biomarkers, in terms of microbiology, so if you're taking sputum culture or nasopharyngeal swabs and suggestive chest X-ray, findings are all supportive evidence for a patient having a treatable trait, which is an infective exacerbation. So it's important because if you have a stable patient who has no clinical symptoms, you don't have X-ray findings that are suggestive of a pneumonia, and you isolate something on a sputum culture or nasopharyngeal swab, that does not necessarily require treatment. And that's important. So if you have the right clinical history with the right supporting evidence, then that is most probably an infective exacerbation. So I've just given very broad principles of antimicrobial management in this group of patients, because it does differ by where you are, which hospitals you're in, which wards you're in, etc. So firstly, in terms of acute infections in chronic respiratory diseases, you must manage the underlying respiratory disease. Again, I'll focus on COPD, asthma, and bronchiectasis, because those are the three big groups of patients that we see. So the antibiotic indication in COPD is actually for severe exacerbation or patients who require invasive ventilation. And this is with biochemical and imaging support of an infective process. There was a 2018 Cochrane review that looked at 19 randomized studies and compared antibiotics to placebo in 2,663 patients. And the antibiotics were effective across outcomes for patients with severe exacerbation, and the quality of evidence for this was low to moderate. In terms of mild to moderate exacerbation, there was really inconsistent results amongst patients. So if you come in with a severe exacerbation or requiring ICU admission and invasive ventilation, and you have biochemical and imaging support of an infective process, then these patients warrant antibiotics. You do take a sputum sample for MCS, and if you have cultured something, then you can narrow down your antibiotic choice. But remember that you must also keep your local antibiogram in mind. If the patients are antibiotic naive, you target the typical respiratory pathogens, and you would include pseudomonal cover in certain subsets of patients. So who are the patients who are at risk for pseudomonal infections? So these are patients who've had recent hospitalizations. If you've had 4 or more courses of antibiotics in a year, or you've had recent antibiotics in the last 3 months. If you have severe disease, so if your FEV1 is less than 30%, or you've previously isolated Pseudomonas during an exacerbation, or you're known to be colonized with Pseudomonas, then you would include anti-Pseudomonal cover as part of your empiric choice. If the patients are antibiotic experienced, which oftentimes we do see, you consider what antibiotics they may have received previously, you consider the previous culture result, and any other new additional risk factors that they may have been exposed to, so hospital exposure, ICU exposure, and you tailor the antibiotic choice accordingly. your treatment duration, 5 days is sufficient. In terms of influenza, if they've presented within 48 hours, then you do treat with oseltamivir, and the treatment duration is 5 days of treatment. There is an asterisk in the guideline that says that even if you've presented more than 48 hours, but you're still considered high risk, so the extremes of age, if you're pregnant, you've got various underlying chronic conditions, then you would still treat with oseltamivir for a duration of 5 days. When we look at bronchiectasis, again, it's always advisable to take a sputum culture. If they're antibiotic naive and they don't have any previous microbiological data, then you cover the typical respiratory pathogens. If they're antibiotic experienced and they've had previous microbiological data, then you tailor the antibiotic treatment and include pseudomonal cover if they're at risk. I found this quite interesting because a few guidelines have suggested that the treatment duration for bronchiectasis is actually 14 days. So when I went back and looked at it, it's actually based on low quality evidence and really on expert consensus from previous studies that have shown good clinical outcomes in patients who've been treated for 14 days. Unfortunately, there's no head-to-head studies that compare 7 days versus 14 days in patients with bronchiectasis. There is indirect evidence to suggest that if you have a mild to moderate exacerbation and a fairly sensitive organism, then you can treat for 7 days. However, if it's in a severe exacerbation or you've isolated a resistant organism, then it's better to treat for 14 days. But again, the quality of evidence here is quite low. And asthma, the treatment strategy will be similar to COPD. So I've just put in our 2016 community-acquired pneumonia guidelines, and just to emphasize that normally our first-line treatment targeting our respiratory pathogens is amoxicillin or ampicillin. In patients who present with severe CAP and who are more than the age of 65 and have comorbidities, they would fall under this group where you give amoxicillin clavulanate or a second or third generation cephalosporin and a macrolide. And I just wanted to emphasize that the use of the macrolide in this particular scenario is not to cover for atypical pathogens. The use here is that it's been shown that combination therapy with a macrolide has actually has been associated with better clinical outcomes. So this macrolide addition is not there to cover for atypical pathogens, but is rather there because the data has shown better clinical outcomes. Remember that patient in South Africa, atypical pathogens cause less than 2% of cases of pneumonia. And again, like I'd illustrated before, they're not common organisms when it comes to infective exacerbations in chronic respiratory diseases. Of note, though, it's always important to remember that patients who are at risk, so if there's specific risk factors that your patient has for the atypical pathogens, then you should be covering for that. So in terms of, just to mention a few, in terms of mycoplasma, if they live in closed living conditions like school or military barracks, they may be more at risk. In terms of Legionella, if they're exposed to stagnant water sources, so humidors, whirlpools, water faucets, air conditioning, they may be at higher risk. And things like chlamydia, coxiella, if they've had animal exposure, may make them higher up on the list. And if they're elderly, they may be more at risk for, if they're elderly with these exposures, they may be more at risk for atypical pathogens. So just a word on that. In terms of antimicrobials in chronic infections, again, manage the underlying respiratory diseases. Depending on the causative agent of the chronic infections, you treat with the appropriate agent and duration, and that applies to MTB, NTM, and fungal causes. And cystic fibrosis, I haven't touched on it all because it's a talk on its own, but just to remember that inhalational antibiotics for cystic fibrosis is also important to remember in this category. And finally, coming to preventative strategies. So this includes vaccinations and macrolide prophylaxis. So in terms of vaccinations in patients with chronic respiratory diseases, so it's recommended that pneumococcal vaccine series, annual influenza vaccine, and COVID-19 vaccine should be administered to patients with chronic respiratory diseases. This is taken from the 2024 GOLD guidelines, which recommend influenza, SARS-CoV-2, and pneumococcal vaccine. In addition, the CDC recommends RSV vaccinations to patients who are over the age of 60 and who have chronic lung disease, and pertussis vaccinations if they've got COPD, but they weren't vaccinated in adolescents, and zoster vaccine if to prevent shingles in people with COPD and they're over the age of 50. This is the CAPITA study. So this just shows the efficacy of pneumococcal vaccination in adults. And you can see here the cumulative episodes of vaccine type, community-acquired pneumonia, abacteremic and non-invasive community-acquired pneumonia, as well as invasive pneumococcal diseases, are all lower in patients who've been vaccinated versus those who haven't. In terms of influenza vaccine, this is the Cochrane review. And I've just highlighted here that patients who were in the placebo group had 0.83 to 1.35 exacerbations, whereas those who were vaccinated, their incidence ranged between 0.11 to 0.64. In terms of macrolide prophylaxis, and I think I've got 2 more slides, I just wanted to mention this in chronic respiratory diseases. So the macrolides as a group were chosen to for prophylaxis because they have good tissue penetration, they have prolonged tissue persistence, and they have favorable side effect profiles. So they're quite tolerable, but they do have significant side effects, which we do need to watch out for, and I'll mention those in a slide or 2. So how do macrolides work? And why do we think it works for patients with COPD and bronchiectasis exacerbations? Well, this is based on several trials, including the EMBRACE trial, BAT trial, BLESS trial. And what they found is that you have bactericidal effects of the macrolide, but also non-bacterial effects. And the non-bacterial effects, which are thought to be immunomodulatory, is that you have increased phagocytosis of apoptotic neutrophils, reduction in chemotaxis, as well as pro-inflammatory cytokines and reactive oxygen species, which reduce chronic airway inflammation and mucus production, which results in better airway clearance, better mucociliary clearance, which reduces your chances of infective exacerbations. You also have reduced bacterial virulence and reduced biofilm formation around virulent organisms. So the dose of macrolides that's been used is either 500 milligrams 3 times a week for 12 months, or 250 milligrams or slightly lower dose daily for 12 months. And this is given for patients who are frequent exacerbators, where they have 2 or more exacerbations in a 12-month period. This is the Cochrane review looking at placebo versus those who received macrolides. So this is in a few countries, and you can see here in terms of exacerbations, with more than 1 exacerbation, in the risk with placebo was 714 per 1,000, and the risk with macrolides was 459 per 1,000, with an odds ratio of 34, which meant a 66% reduction. In terms of hospitalization, you had 133 per 1,000, and then with the macrolides, you had 79 per 1,000 with an odds ratio of 0.56, so 46% reduction. And you can see here the evidence ranges from low to moderate. This is looking at placebo versus macrolides in China and Spain. And again, if you look at the risk of exacerbations in the placebo group, it was 762 per 1,000, whereas those in the macrolide group, it was 498, with an odds ratio of 0.31, which is a 69% reduction in exacerbations, and the quality of evidence here was moderate. In terms of COPD, you can see that the absolute rate of exacerbations was 1.34, so 127 fewer per 1,000. And then this is looking at serious adverse events, which were also found to be lower. It is important that if you are giving patients macrolide prophylaxis, that you should be checking the ECG to look for QTc prolongation. NTM must be excluded before you even consider giving macrolide prophylaxis, because your macrolides form one of your core drugs for NTM treatment, and this is an absolute contraindication to macrolide prophylaxis. Audiology assessments also need to be done periodically in patients who are going to be on long-term prophylaxis. So my take-home points for this talk really are to emphasize what an exacerbation is. So to identify an exacerbation, it's important to correlate all parameters, so clinical blood biomarkers, microbiological data, and imaging results to determine if the exacerbation is infective. And once you have suspected an infection, you must be aware of what the patients previously have cultured on their microbiological results, as well as their previous antibiotic exposure. And also, please remember any new risk factors and tailor the antibiotics accordingly. The answer is not always augmentin, and please remember viruses do form a large part of important triggers, and you don't need to give them antibiotics for that. Prescription for antibiotics unnecessarily in COPD has been leading to antimicrobial resistance, and it's a big problem. So
I lost. Oh, Sharon, are you there?
yes, I am.
Oh, sorry. Okay. Sorry. We lost you for the last 5 seconds. Okay.
Oh, sorry.
No, that's fine. Okay. Thank you. Sorry. Thank you so much. I find this group of patients quite difficult, and I think that most people will give patients an antibiotic, especially in the COPDs and the bronchiectasis, potentially the asthmatics less so. So it was really nice to go through all the kind of evidence, and I don't know, I think that it's nice to see where our biases lie, like in what we've heard, and then we just continue to kind of treat patients potentially with low quality evidence. So there are some questions.
Sure.
So let me just go back here. So Eunice wanted to know that if in this, can you see the questions? In the anthamycin trial that you were talking about, if there was a control used, or what control was used that devised the clinical criteria. Do you know anything?
So you mean the one in the 1980s, I'm assuming the old trial?
Yeah, to devise, yeah.
So I think the first, if I'm not mistaken, the control group were healthy subjects. But I would have to look at that. I didn't look at that trial extensively. So I'm not sure who exactly they had used as the control group.
Okay, all right, that's fine, thank you. And then there's someone, her name is Helen, I think Loden. I'm not entirely sure what the question is. So initially she said, what's the current opinion with regards to the use of steroids, whether they're systemic or inhaled, with an acute infective episode? So I thought that potentially this was in the management, but then I must maybe just unmute you. It says, then you were saying what specifically with patients who are on DMARDs or biological agents. So I'm not 100% sure if, Helen, you are trying to, let me unmute you so that you can actually, because I don't know if you are saying whether you want to give steroids or, wait, here we go. How do I do this? Sorry. Unmute, there we go. Okay, you should be able to unmute yourself now. Can you maybe just explain exactly what you meant by the question?
Hi, can you hear me now?
Yes.
Oh, apologies for calling you Jeremy.
No, don't worry, it says Jeremy. No, it says Jeremy, so you don't have to apologize.
No, I know we've been talking about bronchiectasis and that category of patients, but I'm thinking about those patients that are immunocompromised on disease modifying agents. Obviously, they are very at risk of respiratory infections, and it's been my experience that they're given both inhaled and intravenous steroids in quite large doses with the antibiotics that you've mentioned, including the erythromycin group. But I just wondered about the steroids because it's a bit of a double whammy, isn't it? Because they are immunocompromised because of their treatment therapy to subdue their autoimmune disease. that was the meaning of my question.
Thank you so much for clearing that up. Sharon, so would you give steroids to someone who's already immunocompromised who came in with an acute exacerbation, whether it be asthmatic, bronchiectasis, or COPD? But I think bronchiectasis was maybe the main question.
Yeah, so I didn't come across any particular specific literature where you used inhaled and intravenous steroids for treatment of an infective exacerbation. I think that you would probably use the steroid if there was an indication to use the steroid for the underlying respiratory condition, but I'm not
Yes.
aware of it being used particularly for an infective, like if anybody even if it was an immunocompromised patient and they come in with an infective exacerbation, I'm not aware of just routinely giving steroids as part of eradication.
Okay, no, thank you, Sharon. And you have a marvelous way of explaining. So this was an excellent presentation. Thank you.
Thank you.
Yeah, I think just from my point of view, I think that if you have bronchospasm, particularly obviously in your asthmatics and your COPD patients, then a steroid is going to assist with the bronchospasm. But yes, I think otherwise routinely just giving them for an exacerbation, I don't think I've come across anything like that. Okay, so we've got only a few more minutes. I just want to see here. So it says, among at-risk patients, how would you cover empirically for Pseudomonas? One anti-Pseudomonal antibiotic or versus two? So whether you're giving, so sometimes when you have Pseudomonas, they will give combination therapy whilst awaiting sensitivities. So I think what Denise is saying is, if you are worried about someone who's coming in with an acute exacerbation and they have risk factors for Pseudomonas, would you use one or two antibiotics?
So I think in our setting, we use one anti-Pseudomonal agent. I think the evidence for two anti-Pseudomonal agents is not strong. So I would say that we would start off with one, and then obviously depending on resistance of the particular Pseudomonal isolate, you may decide to use combination therapy. I know combination therapy in general is not great, but yeah, I would probably start off with one, and then depending on culture and susceptibilities, add additional cover if needed.
And then the last question, and I don't know if you did come across anything like this, but I think a couple of people have said that if you have someone with chronic lung disease and you diagnose them with Pseudomonal or a pneumonia or an exacerbation secondary to Pseudomonas, but it's just the first episode, would you attempt eradication therapy at that point? I don't know if you've read anything about that.
So I don't look, I'll be honest, I didn't read extensively around Pseudomonas eradication therapy. I know in cystic fibrosis patients there is an attempt at trying to eradicate for Pseudomonas, but in non-cystic fibrosis bronchiectasis, I don't think it's advocated to attempt eradication therapy in those patients. So yeah, I think it's sometimes, yeah, I didn't touch this on the talk, but with cystic fibrosis on its own is a huge topic, and treatment, whether it's inhalational as well as eradication therapy, applies mostly to that subset of patients, whereas in non-cystic fibrosis bronchiectasis, they haven't really spoken about eradication therapy as much. So I think the patient cohort that it's referring to is mainly to your cystic fibrosis patients.
Yeah, I'm sorry, I can't really add much else on that. I'm not 100%. I know that there's obviously clear guidelines for cystic fibrosis patients, but whether you can extrapolate that to bronchiectasis, I'm not 100% sure. So I'm sorry, I'm not. I can't really assist with that. Okay. Lots of people have been saying thank you so much. It's a really difficult topic, so thank you for breaking it down into kind of bite-sized pieces and giving us kind of a like take-home point on what you think we should be doing with our chronic lung disease patients who come in with an exacerbation. So thank you very much.